are going to hear from a few of our female legislators who are working to ensure Texas women, children, and families have the health resources they need. I want to start by saying we have come a long way in addressing these issues. Prior to chairing the Senate Finance Committee, I chaired the Senate Health and Human Services Committee, and I had to fight for a number of resources. For example, when I was first elected, the Women's Health Program didn't exist. Medicaid didn't cover early treatment for breast or cervical cancer. You remember Chairman Thompson. And there was little in the way of education about the unique health care risk for women. I dug in, worked hard to learn the issues, and went on to become the longest serving chair, male or female, of that committee. Health and Human Services makes up 34% of our budget for the current biennium. Funding for women's health is at an all-time high, an increase of $65 million over the previous budget. We are combating human trafficking, a $60 million investment. We provided $54 million in additional funding to address the sexual assault kit backlog, thanks to which we have decreased the backlog by over 1,000 kits, and we increased funding for domestic violence shelters. Progress on these issues would not be possible without women leading the way. When I was first elected, there were only 4 women serving in the Senate. Today, we have 10, and I'd love to see that number grow. That is where Texas Women University's Jane Nelson Institute for Women's Leadership comes in. The Institute is dedicated to preparing more women to take on successful roles in business and public service. Throughout these difficult times, the Jane Nelson Institute for Women's Leadership has provided $1 million in grant funding to women-owned businesses affected by COVID-19 and provided business advertisement services to more than 100 women-owned businesses. We also have the Public Leadership Education Network, the only national organization with the sole focus of preparing college women for leadership in the public policy arena. Each year, Texas Women's University's Center for Women in Politics and Public Policy provides full scholarships for students to attend the 6 PLEN seminars. Thank you to all for promoting women's leadership. Well, now, without further ado, it is really, truly my pleasure to introduce today's panelists from the Texas Legislature. The panel will be moderated by Shefali Luthra, a reporter for the 19th, which works to empower women to be equal participants in our democracy. Great panel. Our panelist includes Chairman Senfronia Thompson, the Dean of Women Legislators. Representative Thompson is the longest serving woman and African American in Texas history. She is the chair of the Texas House Public Health Committee. A breast cancer survivor, Representative Thompson passed legislation that makes insurance companies in Texas pay for the cost of 3D mammograms, the most effective technology for early detection of breast cancer. We also have Representative Donna Howard, Vice Chair of the House Administration Committee and a member of House Appropriations. She previously served on the front lines as a critical care nurse and served as Austin's first hospital-based patient education coordinator. Representative Howard passed a bill last session that addressed campus sexual assault at colleges and universities with prevention, care, and fairness. Finally, Representative Stephanie Klick, a registered nurse who has almost 40 years of nursing experience. She's done it all, from candy striper to nursing supervisor and nursing consultant. She chairs the Elections Committee and sits on Human Services and the Select Committee on Healthcare Cost. Chairman Klick has worked to expand the state's compassionate use program, as well as healthcare access for women in rural areas. What a great group to be serving on today's panel. Thank you all for participating in today's seminar. You are each strong contributors to Texas healthcare policies and examples of why we need more women in the public policy arena.
Great. Shefali, take it away.
All right. Well, that was a great introduction, super helpful. But I was thinking maybe to start the conversation, we could go around and if each of you representatives would like to share how you came to politics and then how you came to health policy specifically, and then we can go from there. I have a few questions in mind, but obviously you all are the experts and I will defer to you in terms of what you think is most important to discuss. But should we start with Representative Thompson, then Klick, then Howard?
All right, I came to politics from the classroom. In 1972, I had an opportunity because of a lawsuit that created single member districts within the state of Texas for legislative and Senate seats. And I had the privilege of being able to have a seat that was drawn in the area where I reared and lived for most all of my life. And that, having been a participant in other people's campaigns, I was always interested in politics, and I felt like that I could bring something new to the table. Being a female, being a mother, being a wife, being a teacher, I thought that I can bring more to the table to be able to address a lot of issues that I was able to see on a day-by-day basis, and particularly having been a parent. So that was my entry into politics.
And then Representative Klick.
Well, I actually got politically involved in college, and I like to affectionately blame my husband. He came from a family that was very politically involved, and while we were dating, I became politically involved too. But over the years, was very interested in policy issues, supporting candidates that embraced the policy goals that I had. I was a volunteer on many, many campaigns. There was an opportunity with an open seat. I looked at who might possibly run, and there are very few people with a healthcare background. Representative Howard and I are the only nurses in both chambers, and you know we have some professional and subject matter expertise, and so I made the jump and ran and was elected, and have served 4 terms. Each session, I've been on the Human Services Committee, in that I use my seniority choice for that committee. For the other members of the legislature, that means that you're really, really interested in these issues, and that's absolutely the committee you want to be on. So.
Great. And Representative Howard?
Yeah, I've got some similarities to both of my colleagues. Like Representative Klick, I got involved in politics when I was in college. I went to the University of Texas. I've lived in Austin my whole life, and started UT as a freshman in 1969. And if you have any recollection of history, I know you almost weren't born then, but if you have recollections of history and what you've read about, that was a pretty tumultuous time. Not totally unlike what we're living in right now. And there were a lot of activities happening on college campuses at the time. Lots of organizations being formed, which I joined a bunch of those, some of which had to do with women's health care, as a matter of fact. Some had to do with good government. There were a lot of demonstrations going on and marches, and I participated in those. Also, I guess you could say, like Representative Klick, it was later on, but in 1976, I met my husband working on a political campaign. So absolutely, it has just been something that's been a part of my life, basically, my entire adult life anyway. you know, as a nurse, that background I think has served me well in preparing me for a lot of things that happen at the legislature. I think Representative Klick would agree that nursing assessments and how we approach things are very helpful skills in working with the legislature. And it's also great to have Stephanie involved because we're able to do some things in a bipartisan way to address some of the healthcare issues, which has been great to do. I served on a school board because I got involved with schools after I started having kids. And was not one of those, I have to say, especially to the young emerging leaders now, I was not one of those that had a plan in place to be an elected official. It's in some ways, a lot of women from my generation had to be asked to do things, and I'm kind of typical like that. I was not planning to run for the legislature. Some people asked me to consider it because of my experience on the school board and the school finance issues that we were dealing with. And at first I said no, but I eventually agreed to do it. And I was elected in 2006 in a special election, immediately went into a special session dealing with school finance, and have been there ever since. And it's just an absolutely awesome opportunity, responsibility, and honor to be able to be a part of working with my colleagues on trying to look at solutions for the challenges that face our state, because this is all about making things better for Texans, making things better for Texas. And I'm really excited about talking today about the things that are on the agenda in terms of what we're doing with healthcare and women's healthcare in particular. So thanks.
Great. And all of you, that was really interesting. And I think a lot of that really resonates with what we've been talking about, right? With regard to sort of how women are often conditioned to approach leadership. I, like you, really do want to talk about the issues that we are facing right now. And I think the best place to start is the pandemic. One area I've been thinking about a lot personally and in my own work is what the pandemic has meant for women with regard to mental health, right? And we're starting to see a lot of data emerge that suggests that women, and in particular, right, Black and Latina women are just really facing a lot of the secondary strains of the coronavirus. And I'd love to hear your thoughts on sort of how do we address that? Are there concerns from a policy approach about treating things like depression and anxiety, and where do we go from here?
Okay, well, where are we going to start? Just any of us jump in?
Any of you would like to jump in, and I'd love this to be a sort of a free-flowing conversation amongst three of you.
Well, I know that Ms. Thompson has definitely been approaching and thinking about the mental health part, so certainly want to hear what she has to say. I guess I'll start off by just saying that absolutely it's of concern, especially in regard to the disproportionate impacts on people of color, and those are oftentimes more of our frontline workers who are exposed more, who have challenges with childcare, all kinds of things that are bringing extreme pressure on people that is contributing to stress levels. And it also, of course, is of concern when we're talking about women's health care and the maternal morbidity and mortality issues, where mental health issues are certainly something that the task force that we have, the statewide task force review committee, has indicated that that's one of the primary issues with postpartum depression and getting access to care. And you know, we could talk about the different approaches of how we would address that. You know, some of us would prefer that we expand some Medicaid postpartum, because right now women are cut off at 2 months postpartum. We want it to extend to at least a year, because we know a lot of these mental health issues occur past 2 months postpartum. But what we did pass last time was legislation that did increase the ability for women in the Healthy Texas Women's Program to access some mental health care services. There are certainly some challenges there. And you know, I think we've got a lot of work to do to make sure that this is going to work, and we can talk about it later if y'all want to. But just in general, I would say absolutely this is a huge issue for us, and especially during the time of COVID, it's exacerbated. And so it's something we absolutely need to be paying attention to, and that we need to be ensuring that what we do have in place is funded, and that we have the providers, because this has serious repercussions for a woman's health. And oftentimes the woman is responsible for her family. So it's not only the woman's health, but the family's health, and the ability to be a productive citizen in the workforce.
And let me just add to your statement, Donna. Andrea Yates is the poster person for postpartum depression. And we do need to expand that. And we have tried for several sessions to expand 60 days to 120 days to a year, because we recognize that not everyone comes out of that as quickly as others. And they may need extended time to be able to get over that particular situation. But more importantly, we need to, I think, rely more and make utilization more on telemedicine and telehealth. Now, persons in the rural areas, we need to consider how we end the internet problem that they have, the visual divide. That is very critical, because if we're going to be relying more on telemedicine and telehealth, you got to have an internet, and we have to somehow be able to do that. So in order to be able to assist families more, we have to be concerned. And let me just piggyback on some of the things that you talked about. We have a lot of women who we consider essential workers at this particular time, who do not have good child health care, and that's critical. And they are exposed to everybody because of the work that they do. They have a greater exposure. So we need to think of how we're going to be able to help those individuals. And we have a lot of persons who have just lost their jobs and their insurance. So we have to think about how do we expand Medicaid in order to be able to help those persons, as well as the persons who we have who are under, who doesn't have any insurance at all. How are we going to be able to help those families? And we are working toward trying to bring some solutions. And then we look at other problems like infantile mortality. We've been working toward trying to put an end to that. And I think we've been working pretty consistently in that area. But there are so many other areas that we have been working toward to try to be able to close the health gap that exists. And I just think it's absolutely critical that we make sure that children and families and working families in particularly have good insurance and good coverage, because you can't expect a good worker if they're not a healthy worker.
Yeah, I've had many conversations with our local mental health authority in my county, and there definitely has been an uptick in calls on their crisis line. One of the issues that we had even before COVID is we've got a shortage of mental health providers in our state. And one of the things that we've done in recent sessions is loan forgiveness programs for people that are going to be going to school and studying to be a mental health provider. Hugely important. Some of the executive orders that the governor has passed since the pandemic began have made it easier to use telehealth for some of these services. And quite frankly, I think some of those programs need to be made permanent. Especially in mental health, you will find that patients are a little less intimidated in that environment. Not only is it more convenient for them, but they will tend to open up and they report high levels of satisfaction with using that for mental health services. So I think we've got a lot to look at next session, but the digital divide is crucial. We're seeing it in healthcare, we're seeing it in education. Prior to getting on this call, I serve on the Children's Commission, and we deal with a lot of CPS issues, and that becomes a problem for the courts, people being able to participate in the courts on child custody matters, on child abuse matters. We've really got to roll up our sleeves and address the digital divide around the state.
With regard to the digital divide, which I think all of you highlighted and seems so crucial, right, in addressing things like maternal health and mental health, what policy solutions seem immediately sort of practical in actually fixing this problem that's become so salient now?
Well, last session of the legislature, Senate Bill 11 was passed, and that was an effort in the area of working with children to try to put an end to cyberbullying, suicide prevention, you know, those sort of things. And then I passed a bill, House Bill 906, to be able to put a task force together to track the money, to see whether or not that we're really getting the bang for the buck that we're actually putting there. Are we really making the kind of inroads in helping these children that we are providing monies and things out there for? And I'm waiting for, I guess we're all waiting for what's going to be the outcome of those particular things, because we recognize that we have a lot of disparities within our state. Those disparities have been out there for a long time due to a whole lot of problems that has been created as a society. And once we get more of that information back, then I think that's going to give us an opportunity to be able to see how we are able to, what tools we can put together to solve those particular problems. And telemedicine and telehealth is going to be critical. And we know that the internet is absolutely critical, but I want to see the Medicaid expanded, because I think that we have more person that would be that would access doctor's care. We won't have a condition that they are reluctant to go and get treated that's going to exacerbate itself, that's going to cost us far more money than what it would cost right now. And I think doctors ought to be paid the same price in telemedicine and telehealth as they would if they would have an office visit.
Well, I'll just say, we have been trying to incrementally make some progress with broadband connectivity. I think it was the session before last, we were able to get 25 million into the budget to do a match with the federal government's E-rate program to get broadband connectivity out to all of the school districts in our state, which was a huge positive way to leverage federal dollars for us to get that to happen. Now, there's other steps that have to occur afterwards, because just because you get it there, it still has to get to the campuses, and then it still has to get to the classrooms, and then of course to people's homes. And in some communities, that's a real big challenge still. And I know part of the current federal dollars that we've gotten through the CARES Act are being used for, and whether it's there's several pots of money, but one of the pots of money anyway, is being used for, I think what they're calling it, Operation Connectivity, but whatever it's called, the fact is that there's an effort here to try to provide more connectivity than we currently have. We as Representative Thompson is mentioning, we've seen so many challenges here with COVID, and a lot of these challenges we knew about before COVID. They've just been magnified as a result of COVID. But you know, the governor's executive orders to cut back on some of the regulatory prohibitions that have allowed telemedicine and telehealth to occur, I think this has been a great unsolicited but pilot program, if you will, to show us what can actually work. There was a lot of pushback before from a variety of groups that it would diminish quality. It was not going to be as effective, that sort of thing. Anyway, I think we have found that in fact, it can be very effective. You can still provide high quality care. And so I think we're going to have a hard time putting that genie back in the bottle. It's going to be, we're going to all be clamoring for this. Consumers are going to be clamoring for this. They're going to want to be able to continue to use these options, which are critically important, of course, for our rural areas, underserved areas, for our older population who may need to be home more and not venture out. We may actually see that people get more care than they got before if we can continue to do this. And one of my children is a therapist who has a private practice with a group. and they've gone all online now. I've met with the Psychologists Association. They're of course all online now, and what they are finding is that some of their clients are preferring this option, whereas before they would have been very hesitant to use it. They have found that it actually is in some ways more accessible for them, and a lot of people are considering hybrid business models now once this pandemic is over. So I think that it's really clear that technology is going to be hugely important in how we deliver all kinds of services. We've had some glitches that have shown how Texas needs to do a better job of investing in our IT infrastructure, especially when we saw all the problems that we had with the Texas Workforce Commission at the beginning of all of this, with the unemployment insurance. The fact is that they were eventually planning to be on the cloud, but they weren't there. And we had huge problems. My office, it's probably been a month ago or so since I got this number, but my office, just my one office out of 150, fielded approximately 500 contacts from constituents about problems they were having with accessing what they should have been able to access in this challenging time when they were losing their jobs. So yes, I think it's clear this is going to be some investment of funds we're going to have to find, but I think that we've got to move forward with the opportunities that we have before us with technology, and serving the larger community of the rural areas in particular is going to require a significant investment in making sure that everyone does have access.
And I think one of the interesting sort of subtexts of this point that you're all raising, right, is the groups who disproportionately benefit, right? It is often older Americans, which are more often women. Think about a mom with 2 kids and a job, right, who is probably least likely to do her doctor's visit, right? Telemedicine, when done well, can make that a lot easier. And I think you're right. It's going to be really interesting to see what this looks like in the future. Oh, sorry, go ahead, Representative Klick.
And not only that, but we've been not just telemedicine, but telemonitoring. The hospital district in my area, some of the COVID patients that were not sick enough to be admitted to the hospital, they were using pulse oximetry readings. They had oxygen concentrators in their homes. Nurses were checking in with them to see what their status was, every few hours. And those patients were able to be comfortable at home rather than in the hospital. And I mean, there are lots and lots of applications that COVID has made us aware of and made us more proficient in using.
Let me just mention one other thing too. You remind me of it, Stephanie. Here at UT Austin, Dr. Bukowski, who is a maternal fetal medicine specialist, has been working with the supercomputers here and the math departments and other institutions, and trying to look at how do we look at computational health in moving forward. That really is the new frontier for delivery of medical and healthcare. And one of the projects they were working on before COVID happened, and then they've been able to kind of parlay some of that into what we're looking at with COVID, but is using your cell phones, using the GPS systems to monitor, and this is with their permission, of course, some of the moms that were in their program to determine with computational analysis that I certainly don't know the algorithms for and to understand, but to help determine the ideal time for delivery. And what they're actually finding is they are able to decrease cesarean sections by doing this kind of monitoring, which of course ensures that you have hopefully better outcomes with your birth and with your infant's health. So all kinds of things that could be done that are really exciting, and COVID may push us there faster than we would have gone otherwise.
Actually, since you mentioned it, and it's come up a few times, I think we should talk about sort of the pregnancy-related health outcomes, right? Because this already obviously was a huge concern in Texas, and we've talked a bit on the margins, but I'd love to spend some time thinking about, I mean, is Medicaid expansion something, is it on the table? Are there other policy solutions we should also be looking at? And And obviously, right, these disparities in maternal health outcomes are not solely because of insurance. So what else should we be thinking about? What else should we be thinking about now in the pandemic, but also long after?
You know, one of the areas that Representative Howard and I have worked closely together on is with expanding the ability of nurse practitioners to render care. They're, quality healthcare providers. And in many rural areas and medically underserved areas, they're the provider. And, even if we were to expand Medicaid, there are a lot of physicians that do not participate in Medicaid, and your nurse practitioners more likely will. It's a way to improve access to care, as well as reduce the cost of care. And, Representative Howard and I have worked on that issue for several sessions, and I trust that we will continue to work on it because, it will make a difference in improving access and the cost of care.
Ms. Thompson, you want to say anything before I jump in?
No, I'll let you jump in because since you all have been working on this.
Well, and also I'm very proud of the fact that.
But I want to expand Medicaid because
I know that. That's why I was giving you that chance.
But because I think that, I think we can save a lot of the rural hospitals from going out of business and have the availability there. But more importantly, I think we would have money available that we can do a whole lot of these things that we're trying to get done.
Absolutely. Well, I'm real proud of the fact that I recently was elected to be the chair of the Women's Health Caucus in the House. It is a bipartisan caucus, but it's, it leans more Democratic, primarily because in the past anyway, the focus has been on access to reproductive health care and specifically protecting abortion access. We are really expanding what we're doing now, though, and looking at a wide range of issues that impact people who are seeking women's health services, and I'm even trying to be more inclusive with our language. The fact that I used people seeking women's health services, knowing that there are people who do not identify as women necessarily, but have women's reproductive organs that still need to be addressed with healthcare. So just trying to be more inclusive here, and I'm learning as I go along. It's very helpful to have people who are helping us expand the circle here. But we're looking at the maternal morbidity and mortality issues. We're looking at sexual assault survivor issues. We're looking at women's heart health. We're looking at the disproportionate impact. And, the fact is that unfortunately, women of color are disproportionately impacted by a wide variety of healthcare issues. We already knew from the studies that have been done by the task force that women of color, in particular Black moms, were significantly more impacted. And then we've also now seen the same kinds of things happening with COVID. And I recently saw information that was indicating that we have Black infants have a higher mortality rate. We know that there is systemic racism. We know that there are things that we need to be looking at in the system. Why are these things happening? What can we do to intervene? And I find it a very unfortunate thing that happened in 2017. It happened on the Senate side. The House didn't know about it, but in the final days of session, when we do our budget sometimes, which it happened to be then, and we have to vote up or down on a budget at the end after it comes out of conference committee, we don't necessarily know everything that's gone on in conference committee, and we don't get to do amendments anymore at that point. We just vote up or down. And what had happened is what was defunded was the office that was looking at disproportionate impacts, disproportionality and disparities in healthcare, as well as in other systems like our foster care system. I think that was really unfortunate. It happened at the very time that we as a legislature were professing our outrage at the significant issue of maternal morbidity and mortality, and yet let that go. And I have to question whether or not we would have seen things differently sooner in this COVID pandemic here in Texas if we had had that office still functioning could have alerted us to what was happening rather than it being almost an afterthought and seeing later, oh my gosh, actually this is happening. That we could have perhaps been more prepared and already been addressing some of the institutional issues that were creating this disproportionate impact. There's a lot more things I could talk about, but I will say that I agree with Ms. Thompson that we need to expand Medicaid. One of the things that Representative Klick mentioned was that a lot of the physicians who don't participate, one of the reasons they don't participate is because of the low reimbursement rates. And those reimbursement rates are set by the Texas legislature. I realize it costs money. We have to determine what our priorities are here. But part of the problem is if you're not making essentially enough money to pay your overhead, you're not going to participate in the program. But the fact is that we do need to expand this in some way. I would definitely support the 12 months postpartum, and I'll go out on a limb and say what I would really support is paying for women through the whole perinatal period, because women don't get on Medicaid until they become pregnant. And that means they may have lost some ground in terms of their prenatal care to have the best potential outcomes for their pregnancy. And then they're bumped off 2 months postpartum. We've tried to get them to other programs, but that has not been as successful as we would like. So we would probably, I think, have better bang for our buck if we covered that entire period of, say, 14 years old to 50 years old, or whatever the agreed upon time is, to say that you're going to have coverage. We want you to have healthy pregnancies. When you're ready to get pregnant, we want it to be a healthy pregnancy. We want you healthy. We want the baby healthy. We want you to be able to space your pregnancies, which is one of the best things you can do to have a healthy pregnancy and a healthy baby. So yeah, I mean, I'm going on and on this because I get very passionate about it. I think this is where we could make a big difference in the lives of Texas families if we invested in perinatal care.
Representative Klick, did you want to say something, or should I ask another question?
You can ask another question. That's
I
fine.
was going to ask, I mean, we're talking a lot about insurance, and I mean, just for the sake of discussion, is Medicaid expansion, either of the eligibility period or just the program at large, is that the correct path forward? Or should we also be thinking about subsidizing private plans, for instance, in some way, expanded marketplace subsidies? Is any of that also on the table or within the legislature's wheelhouse?
But I think health plans are something that we need. We always need to look at health plans and see what we need to do to be able to provide better health care for persons. And we haven't expanded. We have had a problem trying to get Medicaid expanded for so long. I just think that is something that I know I'm going to be pushing hard on for that expansion, along with looking at what kind of improvement can we make in the health plans that are going to be offered within our state.
Yeah, I would say that, you know, maybe improving access to private health insurance is something that we really need to look at. If you look at Medicaid nationally, their outcomes are not as good with Medicaid as it is with patients that have private insurance. And we, you know, need to consider whether that is a better approach.
A follow-up question to that, if I may. I'm assuming that's the Oregon experiment we're talking about, correct?
Mm-hmm.
To what extent can we really test for that, given that people who are entering Medicaid versus people entering private insurance may or may not have different sort of like pre-factoring health backgrounds, right? I mean, does that complicate the comparison at all, or?
Not necessarily. I mean, there are something called HEDIS measures, and you know, you can apply those and measure those across different types of coverage, and that would be, you know, a great place to start. In fact, most of the data that compares right now, you know, the statistics that I cited with Medicaid having poor outcomes in private insurance, those are on HEDIS metrics.
Well, I don't have it at my command at the moment, but there are also other studies that do indicate that the care is comparable. And the bottom line is that getting access to care is better than not getting access to care, for sure. And then there's also options that we've looked at, and we're actually doing here in Texas on a very small basis, but the so-called TRICARE option, where you have a third from the employer, a third from the employee, and a third from the state. And there is some success with that model too. So I think we do have to look at a variety of options to see what will best serve our needs. But the bottom line is that we need to ensure the access. And as Representative Klick has brought up before, and it's absolutely true, we have a shortage of providers throughout the healthcare delivery system. So it's not just having the coverage. We also do exactly have to address the provider shortage issue as well. There's a lot of moving parts here, and they should really be looked at in a coordinated fashion if we want to make sure that more Texans have access that they can actually follow through on, and they get the kind of quality care that they need.
Thinking also about sort of the question going back to people who are pregnant and then postpartum as well. I mean, is there room for separate discussions about extending the Medicaid perinatal eligibility versus Medicaid expansion, given, right, that even if you're switching from pregnancy Medicaid to other Medicaid, right, like that's still a logistical loophole that if you've just had a baby could be a challenge, right? I mean, should we be thinking about these differently? And if so, how?
Well, I'll just say that, we do have auto enrollment from the pregnant Medicaid program into the Healthy Texas Women's program. But the waiver that the state has applied to the federal government for here, they're not allowing us to do it in the way that we've been doing it, and is making it more cumbersome. And the concern is that it will decrease the transfer into that next program. And even with the auto enrollment that we have now, we do absolutely have more women enrolled because of it, but they're not necessarily participating. There's still barriers of you're changing from one provider to have to find another provider in another system. And that's not always an easy thing to do. And there may not even be another provider. So it's a cumbersome process, but certainly anything that we can do that helps women transition into the other program. The other thing I was mentioning a while ago about with mental health, that this got added on to the Healthy Texas Women's programs, Healthy Texas Women's Plus. That is also not covered by the feds. We don't get matching funds for that. So that's all coming out of general revenue, which means it's going to have to be re-upped each time by the legislature. They're having to find a way to recruit the providers. It's a whole new provider set that needs to be recruited. Whereas if they were to stay in Medicaid, there's already a network of mental health providers in Medicaid. Maybe not enough, but they're having to recruit from zero in the Healthy Texas Women's program. So, I don't know that we have the best answer. I think if anything, we'd want to have both options. We'd want to be able to expand the coverage with Medicaid, but also be able to help women get into a program like Healthy Texas Women's Plus, if we can make sure we build up the provider network that's going to be necessary for this to even work.
You also mentioned much earlier, and I don't want to neglect this part of the conversation as well, sort of the mindset that we have around tracking disparities, right? To see when they do emerge, and given just the pervasiveness, right, of racial disparities in COVID, I guess I'm wondering if any of you think that we might see the conversation change around sort of what kind of attention this should require and what that looks like.
I didn't hear the last part of your question.
Oh, sorry, just what would it look like does the conversation change around the state's role in tracking health disparities? And if so, what would a successful effort to do so look like?
Well, I hope we go back and start tracking these disparities, and because that's going to be very important in the determining factor of the kind of and the quality of health care that individuals are going to need. I look at it as being very, very important in this respect. Every individual society look for a particular outcome from that individual. And if we want an outcome where we have a healthy person, an educated person, we know that they can contribute more to society than a person who is not there. So I'm thinking that if we can find those disparities and be able to do something about those disparities, to address those disparities, I think that it's going to be a win-win for society, both because that person is going to be able to contribute to society in a multitude of ways, and more importantly, it's going to be less cost on society if we're able to address those particular things.
I think that our colleague, Representative Garnett Coleman, I believe, is the person who is planning to reintroduce the legislation to bring back the Office of Disproportionality and Disparities, or whatever the particular name might be at the time. It's had a variety of iterations, but I think that there's a lot of us that are really wanting to see that reinstituted, that it's critical for us to address a lot of things, as I said, not just in healthcare, but that's one of the primary reasons, but certainly we've seen it across a variety of institutions, and I think we need to have that back in place.
I think another way to look at that is social determinants of health. I mean, that is where we live, work, everything. And there are many things that we know that do not require medical intervention, but you can very greatly improve outcomes for the long haul. And I think that we really need to dig in to some of the social determinants of health, because it's certainly more cost effective in making sure that there's healthy food available for somebody who is diabetic versus treating someone due to complications of diabetes down the road. Those are very, very costly conditions. But if we, apply good health principles and address some of the social determinants, that we can move the needle.
I agree with you, Stephanie, and you hit the nail right on the head, because I was going to come right in and talk about nutrition. On every corner in my district, and I live in the ghetto. I'm not downgrading it. I live by choice, because I've been a part of this community for so many years. There's a McDonald's, there's a Whataburger, there's a Chinese fried rice and chicken. There is a barbecue place, there's a pizza place, there's a fried chicken place, and that's the reason why that I'm seeing all of the liver problems, the kidney problems, the obesity problems, all of those things. And it's good. I love you embracing that we need to get people good food, but they can't get food if they don't have good jobs. And if their jobs don't give them good wages, they can't afford to buy it. And even though we could talk about nutrition and all of the things that they need to do, if they cannot afford these things, they can only afford to go down and get ground meat with 70% lean and 30% of fat. That's all they are able to get. And that doesn't do a whole lot of good, as you and I know, for families. So we have to look at the integrated approach of this, the economic, the health, the education, and a whole lot of other things that need to be involved in this in order to be able to address this problem, because it's costing society too much in terms of people power and in terms of monies that we having to spend. And I just thank you for what the different areas that you're bringing up that we that's so helpful.
Not to switch gears entirely, but the other thing, because I'm keeping an eye on the clock as well, and I do want to spend some time thinking about one of the other sort of large, I think, conditions of the pandemic, which has been its implication for frontline workers. And as I think many of you alluded to, frontline work is incredibly gendered, it's incredibly racialized. And think about all of the essential workers in grocery stores, for instance, or nurses or teachers. As we watch states and the country, try to safely reopen, are we doing enough for these workers? And if not, what does effective care and prevention look like? What role does the state have to play in that?
Great question. Many folks that are frontline workers right now, as we've already talked, have been very stressed due to the positions that they have. And, particularly single mom households, you typically see that, and I have several families in my district that are dealing with this. They're multi-generational households. And one person in the family gets sick with COVID, and it very quickly goes through that household. And, some devastating results. There's one family in my district that 3 members of their family have passed away due to COVID. 3. And the primary bread earner in that household is now gone. And as a state, we're going to have to help support those that are left behind for housing, for food, all of those things. But, living in a multi-generational household is a risk.
It has its advantages, but it certainly has its risks as well.
Yes, it does. It absolutely does.
We have pretty much weekly updates from state agencies, and at one time the governor's office as well, about how things were being addressed, about the amount of the personal protection equipment, the PPE availability, the testing availability, that sort of thing. It's been a challenge throughout the entire pandemic to make sure that we have adequate PPE to protect workers. We had one of those updates today. I don't know if my colleagues were on that call or not. It's something where we can just call in and hear what their report is. And they give us these huge numbers, the millions of masks that have been distributed, the millions of gowns and all that. And it's wonderful, but it's out of context of what is actually needed, because most of these pieces of equipment can only be used so many times. You have to keep replenishing. And that's a challenge for a lot of certain frontline workers, some of whom are being asked to provide their own. I actually heard an interview just recently about the NFL and what they've put in place to be able to play football, where they're having daily testing and certain criteria that have to be met. And if obviously if you have certain symptoms, and how they're isolating, and they're trying to do everything they can to ensure a safe environment for football to happen. And they were asked about, well, can you see this kind of thing happening with schools and with teachers? It's not happening. And there's not the same monetary reward, I guess you could say, in terms of what people see on the front end of football. Certainly there's a huge monetary reward in having an educated workforce that we need to be providing for. But I think that's part of our challenge. How are we going to help protect people if we're not providing them with the basic PPE that they need? We got funding from the federal government, CARES Act funding, that would help to address some of these issues. And the governor has dispersed some of those funds, but he still has about $5.5 billion that he's been holding on to for a while now and has not appropriated, if you will. This has got to be encumbered by the end of this calendar year. There are dollars there that could be used to help our schools have what they need to be prepared. to, you know, we're getting reports, I'm sure y'all are too, from our school districts about the expenses that they're incurring to not only provide PPE, but to do things with their ventilation system, to have to pay for substitute teachers when they have people who have to isolate, to have to expand bus routes and bus drivers because they wanted socially distance on those buses. All kinds of expenses that are coming up that they don't have a budget for. You know, we have those federal funds that could actually be spent now to address some of that. And by the way, just since I'm on budget for a minute, since that's the thing I pay most attention to, you know, we left the last legislative session with a $3 billion surplus. But since we've had COVID and the economic downturn, the oil and gas industry collapsing, we now have a revised budget estimate from our comptroller that's $4.6 billion in the hole. But the governor has $5.5 billion he's sitting on. He actually has at his disposal more than enough funds to fill that hole and still have some left over. So, you know, I think that we do have a responsibility to use whatever resources we have to protect those people that we are expecting to be out there to teach our kids, to take care of us when we're patients, to be at the grocery store stocking those shelves so that we can get the groceries we need, all of those things that we have come to expect. We've got to protect those workers. And as you point out, they are disproportionately women and disproportionately women of color.
Representatives Klick or Thompson, do either of you have elements you want to add or focus on, or?
No, I just want to add one thing. They are women, they are a disproportionate women of color who have children who need good quality health care and not have to worry about how their children are being cared for while they're working.
Oh, and you bring up the other thing, Senfronia, childcare. Mm-hmm. We already knew we had a childcare problem before COVID, but now everybody gets it. That is an essential service. People can't go to work if their kids aren't taken care of.
One thing I've also been thinking about is elder care, right? Given how many often women, right, are in charge of caring for older or disabled relatives, and they're also often medically vulnerable. Sort of how do we fit that into the conversation as well? And what does protection look like when you are trying to buy groceries for someone who is at risk? I mean, who's paying for gloves or masks? You are. The person who's going out doing the shopping and who's doing the caring, and those person are paying for those items, and they have to be extra careful because they are the person that would take COVID to that person who elderly in their home. So it is their responsibility to keep themselves safe and also to be able to assure that the person that they're helping out is safe as well.
You know, one of my cities has a very active senior center, and during the whole pandemic, a group of us gather there twice a week, and we actually deliver to homes grocery items and meals. Some of the restaurants in our community are even preparing meals that we can deliver as well. So, you know, fortunately, in some communities, you've got grocery stores where you can order online and pick up, but that goes back to the whole digital divide. If you've got a household that doesn't have internet access, that's a problem. But, you know, going out, and especially when this began, you couldn't find PPE. You couldn't find gloves. You couldn't find hand sanitizer. It was very, very difficult. And now the supply chain has recovered a great deal, and you can find it. You can even find toilet paper, fortunately. That was surprising that there was a shortage of that. But we need to find other ways, especially if you've got elderly folks at home, that food can be delivered to them, whether it be by community volunteers, as it is in my area, or different services.
Well, we know we have a growing aging population, and there's going to be more and more need. I'll just use my personal example here. I have two sets of parents because they divorced when I was a teenager, but they're all alive and in decent health, but certainly had to be protected. They were all in senior living facilities. Luckily, my mom in San Antonio got brought into my sister's home where she is still, and she's being able to be cared for and get her needs met there. My parents here in Austin got taken into a sister's home here, and they've just actually recently this week gone back to their senior living facility where they were in independent living. We'll see how that goes. But you know, they had family that could take care of them, who had sufficient resources that they could handle it. Not all families can handle that. Not all families can absorb that cost of taking in a family member, especially if they have healthcare needs that have to be addressed. And then just even on my own immediate situation, my husband had a cardiac arrest and brain injury last May at the end of, toward the end of session. He unfortunately died the 1st of August. But all this time, we were, you know, even during COVID, I was taking care of him. And though I, of course, also have the resources I need to have done that, I still needed to try to get home care to help me. The challenges of that are extreme, partially because of the low pay. These are people that don't get a living wage, and they're going to come in and take care of my loved one and help me. And the ones that came that I worked with were phenomenal. They did wonderful work. I'm so grateful. But I also felt the burden of them not getting the kind of reimbursement that they needed. And during the COVID part of this, they were putting their own selves and their families in jeopardy by coming into homes like mine. We were all, of course, isolating. But that being said, you never know when you're going to be exposed to something. And we wore masks and that sort of thing. But it is a huge challenge. And I've seen it up front, close and center now. And we've got to find a way to create a system that supports people staying at home because it's less expensive than being institutionalized. But we've got to be able to pay the people that are providing the care so that the families can support the elderly family members being at home and the caregivers who come in to provide the care. It is, I'm astounded now from what I just lived through. The challenges, the obstacles, and what a huge, difficult situation this is going to be as we have the silver tsunami just wash over us and we have more and more older people, that demographic growing and growing.
Lack of attention to home care, I think you hit on it. It's just such a great oversight in our public policy conversation. And those home care workers you mentioned, right? I've spoken to many of them, and they're often buying their own PPE out of pocket. And yeah, you mentioned, right? Most of them are paid below minimum wage. Like, that's a real financial struggle that can be hard. It can cut into other things as well then.
Right.
If you all don't have other things on this topic, the other sort of last couple things I do want to get to before we run out of time is, I was thinking this morning, I was like, I can't believe I hadn't planned originally to ask them about the election. And I feel like I have to, because healthcare has always been a women's issue. Healthcare is especially important now, and coronavirus is also very important. And we are seeing so much national attention on Texas voters. And I'd love to hear your thoughts on whether you think healthcare, any of the issues we've talked about, or the pandemic could be factoring into how voters in general, but especially women in Texas, approach the ballot this year.
I think so. I think the pandemic has exacerbated that issue to the extent that people are going to be using that maybe as one of the criteria of voting. may not have been a big ticket item before the pandemic, but so many things have happened. Families have lost jobs, they have lost their insurance coverage, they have expired. Persons have gotten ill because of the pandemic, and they are still ill. And there are so many things that that has happened to families, and I think that is going to be a factor that is going to play into this election cycle.
You know, I would agree. Access to quality care has been an issue throughout this. Please remember that back last fall, that was probably when the first COVID cases worldwide were beginning. We didn't even have a test at that point. And we've had to, it's kind of like rebuilding an airplane while the plane's already taken off, as far as the testing protocols, getting PPE out there. One of the things that I learned a number of years ago, that a lot of our personal protection equipment is manufactured overseas. And, I several sessions ago wanted to stockpile some PPE in Texas because I was afraid of a pandemic just as we've had right now and supply chains being disrupted. Wouldn't it have been great if we had done that 4 years ago? But, healthcare definitely is on the minds of a lot of folks. You've had people that have contracted COVID, and while they may have technically recovered, many patients are having long-term health impacts. They're having cardiac, renal, as well as pulmonary long-term problems. And that's definitely going to be on their minds while they may be out of the hospital and home. It's very, very much curtailed their physical health.
Yeah, and I mean, certainly before COVID happened, I think healthcare was obviously an issue for folks, but there were probably other issues that were guiding some of the politics, and especially at a national level. And one that came up a lot was immigration. I'm sure that that's still an issue for some, but I don't think it's anywhere near in the prominence that it once was in terms of guiding elections. Whereas healthcare, no matter where you fall on the political spectrum, you probably have an opinion about how things have been handled at the national level as well as at the state level. And you see the repercussions all around you in terms of what it may have done to your own health or people and what it certainly has done to your pocketbook. If you have a business that is going under, or you've lost your job, you've lost your insurance. And I don't know what the current number is. The last number I remember seeing is there were like 1.6 million more Texans who were uninsured than we had prior to the pandemic. So, it's everywhere for everybody to be focused on right now and to have an opinion about. So I think it's absolutely going to be a factor in the elections, both at the national level and at the local level.
All right, well, this is great. And I have just discovered that there is a queue of questions that have been submitted by our observers. Out of respect to them, I should go through them. My apologies for not doing this sooner. I'm also figuring out the Zoom interface. So the first question was, can you discuss internet access as a public good like the Postal Service?
Mm-hmm.
Yeah, what would that look like? Is that something that should be on the table?
Yes.
We've got to put infrastructure in for areas that have no coverage.
But it's got to be like utilities. Similar to you wanted to make sure that you had a statewide electric grid. You need to have a statewide internet grid, if you will.
And since we are having children to do virtual learning now, it is critical. And let me just throw this in regards to this. Persons who want to build affordable housing in my district, I'm telling them now, you need to do something about making sure there's a lot of access to Wi-Fi. Because when our children had to go to virtual learning, that was a problem of trying to get them to access virtual learning classes because of the lack of the Wi-Fi in areas where they were living. So not only do we have to close the gap of the internet problem in the rural versus the urban, but we have to make sure that we have enough of Wi-Fi around where a person can really access it. And, you know, I'm still buying every month, like a lot of people, you know, this fast internet service, only to find out it's still slow.
All right, great. I'm going to mark that as answered. Thank you for going through this with me. The next thing I'm seeing is that someone asked for more insight as to the opposition in particular to expanding Medicaid. So I don't mean to put the spotlight on you, Representative Klick, but I'm hoping you will be able to sort of walk through what the arguments are against Medicaid expansion.
I would say, number one, it's cost. And at some point in time, the ACA match goes away, and then it becomes a state responsibility to pick up those costs. That is a concern. There are some other states that did expand Medicaid to able-bodied working adults and found in a budget crunch that they were cutting services to some of the most vulnerable populations that Medicaid serves as a safety net. And it's an important safety net for vulnerable populations. So you're having a healthy adult population that's able to work, displacing some of the services potentially to a more vulnerable population. And that's how some states have solved that. I'm very concerned about that because I work with vulnerable populations.
Representatives Howard or Thompson, would you like to weigh in as well, or?
I'm going to defer to my colleague, Representative Howard, because I know she's been working with this on the appropriations bill as well as other committees that she's on.
Well, in terms of the cost, yes, there's a cost. There's a cost with what we're doing right now too. But the bottom line is that we've left something like $110 billion on the table, and would be bringing down another $10 billion each year from the federal government, which are our dollars. They're our income tax dollars that we're paying to the federal government that are not coming back to help Texans. And that would go a long way toward helping us address some of the issues we have. Right now, the healthcare costs are being pushed off onto the local communities who are bearing the brunt of the burden here, the uncompensated care. And that means that our insurance premiums go up to cover it. That means our property taxes go up to cover it at the local level. And you know, certainly a lot of the hospitals, as we've been talking about, have gone under because their uncompensated care, they can't keep up with that without these federal dollars. So yes, there's a cost. We set priorities. We figure out how we're going to do this. We find new sources of revenue, whatever we need to do. And yes, maybe at one point it will go away. We've been told that for the decade or so that it's been in place, that at some point it would go away. But all those years we've been not getting this money, coming here and keep saying that it's going to go away someday. Yeah, but all these intervening years we're not taking advantage of it. And so, you know, I don't quite get the arguments against it, but that has been the pushback from what Stephanie said. I think is the good summary of it.
And I think my only little pitch here is it would cost us 10 cents on the dollar as opposed to 38 cents that we're paying right now. And the monies that we should be getting back, which is our own money, could possibly go to other states. But we need it here for the state of Texas to take care of our own people.
Great. And then the next question that I'm seeing is asking a bit more about, right, we spoke about maternal mortality. What about people who have private insurance but still die during birth, which, as we know, right, is a major problem, is often a racialized problem. How do we create equity in pregnancy-related care?
I think we're really trying to find the cause of what's happening here that's creating the death of the mother. And it's not always a health issue, a health insurance issue, I should say. But we're trying to find out what is it that is creating this situation to occur during birth. And we just happen to know that there has been so many health disparities where persons have not had health care to the extent that may get them over the hump of being a victim to maternal mortality.
Representatives Klick or Howard, do you want to add anything, or?
You can have bad outcomes even with somebody who has full access to healthcare. You know, people have comorbidities. Some of the folks that in the task force analysis, some of these were drug overdoses. Perhaps less to do with the pregnancy itself, you know, other than the stressors and so forth that go with that, but not a physical health condition.
I would love to add in a question as well, actually sort of following on that, which is the role of implicit bias. Is that something we should be talking about amongst, for instance, healthcare providers, right? Given the research that we've seen around, in particular, implicit bias around Black mothers.
Yes, yes, yes. Absolutely.
It is being done. It is being done in a lot of places now. I know here in Austin at the University of Texas Dell Medical Center that they have incorporated into the curriculum addressing this issue, and they're doing interdisciplinary work with the School of Nursing, social workers, others that are involved with the delivery of care, and including addressing what those implicit biases are and how they're permeating the system and what they can do about it. And they're bringing in equity officers to work with it. The Black Mamas Austin are coming in and helping with some things. I mean, we see a lot more happening that are raising the level of consciousness about this with actual efforts to try to redirect our course here so that we're doing a better job.
You know, on some of this too, they've done sentinel event analysis to try to find out what actually happened in the course of care that went wrong, what was missed. And you have seen a number of packets developed which address standards of care within a facility. That, you know, when somebody's blood pressure hits a particular number, that initiates a protocol in place. Once somebody has so much in the way of blood loss, then they become more aggressive. That initiates another protocol. I think all of those are things, you know, they used a number of these approaches in California and turned things around greatly in the clinical area. They've been incorporated into standard of care. And I do think that they will make a difference.
Yeah, and here in Texas, we are specifically addressing some of those AIM bundles of care that Stephanie's mentioning that look particularly at the hemorrhaging aspect and what protocols can be in place that would allow people to know immediately what to do, what to have available, so that the time is of the essence and they can take care of it and save lives.
Great. All right. Next question that I'm just seeing is to ask a bit about the people who are underinsured. And so the person who's asking says that she has a $28,000 deductible, pays $150 per month for the coverage, and doesn't qualify for the ACA, which I'm guessing means subsidies, but I could be wrong. But so yes, how do we sort of address folks who fall into that part of the system?
Well, one of the solutions, because I've been in that very same situation where being self-employed, having a very high deductible, and still having monthly premiums that were very high because you're self-employed and not part of a group insurance. But some of the solutions for folks like that, I go back to the nurse practitioner. They make great primary care providers, and making those providers more accessible in the community. Right now, we have handcuffs on them, and we're not allowing them to do everything that they're trained and qualified to do. But also, I think we need to encourage things like direct primary care. That is where someone pays a monthly fee, and that person that you're paying the fee to, no matter how many times you go in, you can go in for care. Families do that, find that it's significantly less expensive. Many also provide some lab work and diagnostic studies as well as part of that. And, you know, it's affordable, accessible care, and we need to encourage more of that. There are also facilities that do for folks, if you've got need to have knee surgery and you've got a $10,000 deductible. There are some facilities that, as a cash paying customer, you can save significant amounts of money. My husband had a total hip replacement done a couple of years ago. Our insurance paid about $80,000, although it was outpatient, not inpatient. We could have gone to a facility that caters to folks that pay cash, and the cost would have been about $9,000, not $80,000, $9,000. So there, you know, we need to encourage more people direct to consumer products out there.
All right, I think we have time for one more question. So I'm gonna go with this other one in the queue, which is, how difficult, if at all, has it been to ensure federal healthcare COVID aid is being distributed fairly, with transparency and oversight, especially given that y'all are not in session?
That's a wonderful question. Donna is on the appropriations committee. And I'll let us know. Donna, I'm not dumping on you. I'm just.
No.
I know you've been keeping up with the CARES Act money coming in.
And it's been kind of a challenge to get all the different buckets and pots of money straight and figured out where. In fact, we're creating an infographic that I'm hoping to have ready to send out this next week that'll kind of address that. But the bottom line is that, yes, with the legislature not being in session, it makes it more difficult for us to know what's going on and to have the oversight that we normally have. You know, the Capitol is closed, so we're not having interim hearings because we have to have public access to be able to have hearings, and we don't have that. So we would normally be having interim hearings where we'd be talking about a wide range of issues that are interim charges that the speaker gives us. But in addition to that, on top of with COVID and with the economic situation, we would probably be having hearings about that as well. So it has been a challenge to keep up with where things are, what's been spent, and how all this is accountable. And as I said earlier, the bottom line is we got about, I want to say around 11 point something to $12 billion of funding. Some has gone to the school, some has gone to higher education, a variety of things. But the governor does still have about $5.5 billion that he hasn't let go of. So, you know, in terms of if we were in session, I think we'd be able to talk more about that and say, let's figure out where's the best place to put that and start spending it now while we have these needs, because that's what it's for. And we're going to lose the dollars if we don't if we don't actually expend them by December 30th or 31st. I think it's the 30th actually, but anyway, the end of the month, the end of the year.
All right, everyone, we are a few minutes away from ending, and I love deadlines, so we're going to be on time. So what have we not talked about or I not asked you that you would love to talk about or make a plug for before we wrap up?
Well, listen, I had a brain institute bill last session that I believe should be a part of our research here in Texas, and I plan to run with that bill again. I was particularly interested in trying to find out what are the triggers in the brain that are causing our children to be more violent than they are, and what are the things that we can find out that is triggering an increase in depression and schizophrenia and bipolar among our children. And hopefully along the way, we may be able to find out what are some of the triggers to other things that has been a problem within our society. So I'm planning on running with that because we've done a wonderful job with the research here with cancer. And I just think that the brain research would certainly be a big advantage to our society.
And let me just say, I hope that Stephanie Klick and I can continue to work together on some nursing issues. I think that we've done a pretty good job on that, and we still have more to go. Stephanie's been the lead on expanding the APRN's ability to practice to the full extent of their license and training. There's more to do there. I hope we'll continue to work on that. On workforce safety, nurses have a big challenge even without COVID with safety issues in the workplace, and we've been working together on that. And then I guess I would also just say, in terms of the leadership focus of this event, women need to be more in leadership roles, whether it's an elected office, as policy leaders, as people who are movers and shakers in the community, whatever. We need women's voices out there more than ever. And one of the things that Shirley Chisholm said back in the day when she was a presidential candidate was that if you didn't have a seat at the table, then as she put it, you bring your own folding chair. So I use that all the time now, and I would like to pass that on to any of you listening today. Don't wait to be asked. If you want to be a part of finding solutions to the challenges that we all face, if you don't have a seat at the table, then bring your own chair and be a part of the discussion.
I would agree. One of the things that I worked on last session that both of the other representatives on our Zoom session today also participated in is we passed one of the first and strictest fertility fraud bills last legislative session. During the interim, I have learned more, and there's still more work to do. But for those of you that are not familiar with it, these are women that go to clinics for fertility care. They're having difficulty conceiving, and the physicians are using their own DNA or sperm to impregnate patients rather than the donor consented to sperm. And we're finding with consumer DNA that many of these doctors have lots and lots of children out there. They have defrauded their patients. So I was pleased to get that passed last session. And ladies, we've got more work to do next session.
Well, I'll tell you what, Stephanie, I was pleased to vote that bill out of my committee for you because I just thought that was just awful.
All right, everyone. So I think they would like us to do a photo of the panel before we